Okay, we are live. Okay. Good evening, everybody. As a part of Classroom series, today we have Dr. Nathasha, who's an assistant professor in St. John's Medical College in the Neurocritical Care Unit. She'll be giving a presentation on the brain death assessment in the Neuro ICU. Over to you, Dr. Nathasha.
Thank you, Dr. Sendhu. So I would like to thank the Neurocritical Care Society of India for having given me an opportunity to talk on this topic. So let's begin on with the presentation. Now, the scope of discussion for today would be based on the following lines. I'll give you a brief minute on the history of brain death. We go into the definition, the mechanism, the prerequisites, clinical testing, ancillary testing, certification and documentation of brain death, a little into pediatric brain death certification, and the most important of all, communication. So now coming on to the history, basically the concept of death initially revolved around cessation of both cardio as well as respiratory function. But then following loss of this, it was natural that the brain's function also would cease. But however, with the development of advanced life support measures like in CPR or positive pressure ventilation, this brought this into interdependence and the traditional definition of death were into question. So in 1959, the concept of brain death or death by neurological criteria as it is now known was first theorized as Lecoma de Paz by Mollaret and Golan, who described an apneic comatose patient without brainstem reflexes or electroencephalographic activity. Then the neurologists began to postulate that probably neurological function was equal or even more vital than cardiopulmonary function. And this led to defining death neurologically. So in 1968, an ad hoc committee at Harvard Medical School came up with the first clinical definition of clinical definition of brain death as a Harvard brain death criteria, which included both clinical as well as electroencephalographic criteria. In 1980, the ODA Act basically provided a legal basis for neurological detection of death in the US. This was then followed by adult guidelines, which were put forth in 1995 by the American Academy of Neurology, which was then revised in 2010. Now, basically, the US follows a whole brain death criteria, whereas we follow the UK system, wherein for us, brainstem death is a legal requirement of death. As mentioned, the brainstem function is very vital for preservation of life because brainstem harbors centers responsible for attention, arousal, consciousness. The cranial nerves are harbored in there as well as the control centers for breathing as well as blood pressure and heart function. Definition of brain death. Now, brain death, also known as death by neurological criteria, is a complete and a permanent loss of brain function as defined by an unresponsive coma with loss of capacity for consciousness. There's an absent brainstem reflexes and the inability to breathe independently. Now, what is the mechanism of brainstem death? Now, initially, a neuronal injury happens, which in turn leads to neuronal swelling. This in turn causes an increase in the intracranial pressure. Now, as the intracranial pressure increases, the cerebral perfusion pressure decreases. There's a decrease in the intracranial blood flow, and this basically initiates an entire cycle. So, when the intracranial pressure exceeds the mean arterial pressure, it becomes incompatible with life. Now, basically, the loss of brain function typically progresses from a rostral to a caudal fashion, with the loss of brainstem function occurring last, owing to its resilience to anoxic injury. And within the brainstem, it is the medulla which is the last to cease functioning. Now, although brain death is a clinical diagnosis, there are certain minimal clinical criteria which are required. Prior to proceeding on to clinical testing, the prerequisites have to be fulfilled. The first one is there should be a clinical bar neuroimaging evidence of an acute CNS catastrophe, which basically states that this particular coma is irreversible. Now, this could involve anything from a severe cerebral anoxia resulting from either a cardiac arrest or drowning. It could be a traumatic brain injury. It could be an IC bleed. It could be a subarachnoid bleed. It could be a space-occupying lesion, or it could be even an infective etiology. The second prerequisite is that the patient's core temperature has to be maintained at 36 degrees centigrade. Now, this could be done either with the use of warm blankets, thermal mattresses, warm fluids, or warm oxygen. The systolic blood pressure has to be maintained at around 100 millimeter of mercury or a MAP of at least 60 millimeters of mercury. Now, this may necessitate volume resuscitation or inclusion of vasopressors plus or minus inotropes. The third step includes excluding all confounders. Now, there are various confounders. One of the most common one which we encounter in our ICU is probably pharmacological paralysis. A train of force stimulator is going to help you out in excluding this. CNS depressant medicines, which may include toxins also. A toxicology screen may be mandatory. Serial drug levels should not exceed the therapeutic range. And now, assuming that the patient has a normal hepatic or renal function, we need to allow at least 5 elimination half-lives of the drug. Now, in case there is concern about prolonged or unknown drug elimination when you're not sure, in those cases, ancillary testing is recommended. If alcohol intoxication is suspected, a blood level of less than 80 milligram per percent is recommended. Any severe metabolic or endocrinal dysfunction, any acid-base derangement, all this has to be corrected before proceeding on to clinical testing for brain death. Other confounders could be a locked-in state, Guillain-Barré syndrome, or a high cervical spine injury. Now, just prior to proceeding on to clinical testing, in order to ensure that this particular cause is irreversible, an adequate observation period is recommended. Now, for most neurosurgery or neurological problems, we usually wait for around 4 to 6 hours. However, an observation period of at least more than 24 hours is recommended when brain hypoxia has occurred because of drowning or cardiac arrest. And in any condition of drug intoxication wherein you have no screening facilities, an observation period of 50 to 100 hours is recommended. Proceeding on to clinical testing. First of all, coma has to be established. Now, this includes applying deep pressure to all of the following. That is, the condyles at the temporomandibular joint, supraorbital notch bilaterally, the sternal notch, and all four extremities, both proximally as well as distally. There should be no evidence of arousal or awareness to a maximum external stimulus which has been applied. Now, the response which is consistent with brain death, as mentioned, these noxious stimuli should not produce grimacing. There should be no facial muscle movement or no motor response of the limbs other than spinally mediated reflexes. Any noxious stimuli which is produced, which is given above the foramen magnum, should not produce any movement in the face or the body. And below the foramen magnum could elicit spinally mediated peripheral motor reflexes. Now, special considerations to be taken over here is that sometimes it may be very difficult to differentiate between spinal as well as brain-mediated motor responses. This may require expertise. However, if interpretation is very unclear, ancillary testing is recommended. Ancillary testing is also recommended if a person has pre-existing severe neuromuscular disorder like an amyotrophic lateral sclerosis or a pre-existing severe sensory neuropathy. Severe facial trauma or swelling which may preclude evaluation of facial motor response. In these conditions also ancillary testing may be recommended. Going on to the next test, which is a pupillary reflex, wherein we basically test the afferent and the efferent, that's the optic and the oculomotor nerve respectively. The region tested is the upper brainstem. Now the test over here is we shine bright light into each of the person's eyes and we look out for pupillary reaction as well as the size. The response which is consistent with brain death is that there should be absent pupillary response, both in the ipsilateral eye as well as a contralateral eye, and the pupils will be fixed in any position, like kind of mid-size to a dilated position ranging from 4 to 6 mm. In this case, a quantitative pupillometry is, although it is not validated, but it could be of great help. Considerations would be constricted pupils could either suggest the possibility of drug intoxication or a locked-in syndrome. Ocular installation of particular drugs may actually produce transiently non-reactive pupils. Now, the pupils could be of any shape. Pupils could be round, they could be oval, irregular. It is immaterial to diagnose brain death. A corneal trauma or prior ophthalmic surgery may also influence pupillary reactivity, and this may necessitate an ancillary testing. So also anophthalmia or inability to see the pupils well. Coming on to the third part, which is basically the corneal reflex, wherein the afferent, that is ophthalmic division of the trigeminal nerve, and the efferent, that is the facial nerve, is basically tested. Now here what is done is, this is just a video to play it out. So basically we touch the cornea of both the eyes with a cotton swab and you apply a light pressure that is at the external border of the iris. And what you're looking out is for eyelid movement. Now, a response which is consistent with the brain death or death by neurological criteria, there will be no eyelid movement. Now, care should be taken over here that so that you avoid damaging the cornea, because this could be a potential organ donor site. And in the setting of anophthalmia or severe orbital edema, prior corneal transplantation, severe scleral chemosis, ancillary testing is often recommended. Coming on to the next test, which is an oculocephalic and the oculovestibular reflex, wherein basically we are testing the middle brainstem. Now, when an oculocephalic reflex, now prior to proceeding on to this, it is very important that you have to see to it that you have to maintain the integrity of the cervical spine. If any doubt arises as to a cervical spine injury, an OCR has to be aborted, and you can just proceed on with the oculovestibular reflex. Now, when an oculocephalic reflex, you're going to rotate the head briskly, horizontally to both the sides, or you can even rotate it vertically. Now here basically we are testing the third, sixth and the eighth nerve, and an absence of extraocular muscle movement is basically compatible with brain death. Coming on to oculovestibular reflex or the caloric test. Now prior to proceeding on to this, an otoscopy has to be done in order to examine for patency of the auditory canal and an intact tympanic membrane. Next step would be to elevate the head end to 30 degrees in order to place this horizontal semicircular canals in a more vertical position. Now, how do we proceed on with the test? You take about 50 ml of ice water and you irrigate each ear with over a period of 1 minute. You have to test both the sides separately, and you have to keep a time interval of at least 5 minutes between the testing in order for the temperature of the endolymph to re-equilibrate. Now, as mentioned, a response consistent with brain death will be absence of extraocular movements. Considerations already told. OCR cannot be done if you have any suspicion of cervical spine injury, in which case OVR is to be performed. You have to ensure that the tympanic membrane is intact, because presence of a ruptured tympanic membrane may in turn, when you do the test, you may risk introducing infections into the ear. The next one being a fracture of the base of skull or the petrous temporal bone may obliterate the response on the side of fracture, and ancillary testing would be recommended in these cases. And also severe orbital edema, scleral edema, inability to open the eyelids, all these could, and anophthalmia may actually affect the free motion of the globes, in which case ancillary testing is recommended. Now coming on to gag as well as cough reflexes, wherein we test the glossopharyngeal nerve as well as the vagus nerve. Now, cough reflex is usually done by stimulating the tracheobronchial wall up to the level of carina with a suction catheter. Now, you watch out for cough reflex. On the other hand, gag reflex is usually done by stimulating the posterior pharyngeal wall bilaterally with the tongue depressor, and you use the suction catheter and you stimulate it. Now, response consistent with brain death will be an absent gag reflex as well as cough reflex. So just to put everything in a nutshell, brainstem reflexes have to be tested on both sides. Pupillary reaction to light tests the midbrain. The corneal reflex and the caloric test will give you an idea of the pons. And the lack of cough reflex, gag reflex, as well as an apnea test will give you an idea of the medullary function. Now, ideally, the next question is like they say that the Australian and the New Zealand Society of Intensive Care Society basically puts forth a thumb rule saying that if both sides cannot be tested, at least 1 ear and 1 eye has to be tested. Now, coming on to the most important part of apnea test of brain death certification being the apnea test. Now, here the goal is to allow the partial pressure of carbon dioxide to increase with the CNS pH to decrease to a level which will stimulate the respiratory centers in a functioning medulla. Here, since it elevates the intracranial pressure, this test is usually done last after the rest of the clinical evaluation has been completed and it has been found consistent with brain death. The patient should have no spontaneous respirations when the ventilator is set on a spontaneous breathing mode. And it is always preferable that it be performed by personnel with experience in resuscitation should the patient decompensate during testing. Now, before commencing the apnea test, there are certain prerequisites. The systolic blood pressure should be maintained at 100 millimeters of mercury, or the MAP at least 60 mercury. Temperature should be at least 36 degrees centigrade. Adequately pre-oxygenate the patient with 100% oxygen for at least 10 minutes to obtain a PaO2 of 200 millimeters of mercury. Minute ventilation has to be adjusted to establish normocarbia, which is often confirmed by ABG prior to apnea testing. A functioning arterial line would be preferable because it will help you when quickly withdrawing blood gases, as well as will give you a beat-to-beat monitoring of the patient. Now, what is done over here, after the prerequisites have been fulfilled, you will disconnect the patient from the ventilator. You will maintain oxygenation by the following techniques. That is, you can either apply positive airway pressure with a CPAP, or you can apply a PEEP valve to the end of the T-piece, or you can directly insufflate the trachea with oxygen with the help of a tracheal cannula with oxygen at around 6 to 7 liters per minute. So this is usually done for about after about 10 minutes of commencing apnea testing, and EBG is basically taken. If a point of care testing is available and the patient is stable, you can keep the patient off the ventilator with repeated ABG sampling every 2 to 3 minutes until a target of PCO2 of 60 millimeter of mercury is reached. However, if POCT is not available, you have to reconnect the patient to the ventilator after 10 minutes and an ABG is done. So the target is attaining a PCO2 of 60 millimeters of mercury unless the patient has a pre-existing hypercapnia, in which case you have to see to it that the PCO2 should be at least 20 millimeters of mercury above the baseline. Now, apnea test is aborted if spontaneous respirations are witnessed, hemodynamic instability persists despite titration with fluids, inotropes, or vasopressors. The patient is having sustained desaturation below 85% and unstable arrhythmias occur. Now, if after doing all this, if the apnea test is inconclusive, that is, you are not able to reach the PCO2 goal, but the patient has been stable during the testing, that is, both from pulmonary as well as hemodynamic standpoints, you have to repeat the test after re-establishing pre-oxygenation, normocapnia, and you have to extend the test by few minutes compared to the previous one. Now, what do you do if cardiorespiratory instability happens? You have to abort the apnea test. You send for an EBG at that particular time. If your target PaCO2 is met, the apnea test is considered positive. What happens when spontaneous respirations are witnessed? Again, you abort the test. You repeat it after 24 hours if the clinical evaluation remains consistent with brain death. And if the apnea test has been aborted and you cannot repeat it safely, an ancillary testing has to be performed. So this so initially you have to establish an irreversible cause, demonstrate there is an absent brainstem reflexes, absent respiratory drive with the hemostatic factors within normal range, and then you come to a diagnosis of brain death. So these are a couple of conditions which are compatible with brain death. For example, spinal reflexes, the most commonly seen Lazarus sign. The patient could be sweating, blushing, there could be tachycardia. He may be normotensive without the requirement for pharmacological support. There could be absence of diabetes insipidus. However, decerebrate, decorticate posturing, any extensor or flexor responses to painful stimuli, seizures is incompatible with brain death. Now, confirmatory tests. Now, ideally in India, confirmatory test is not mandatory, as mentioned in the THOA Act. However, in the following circumstances, that is, when you are unable to complete all aspects of the minimal clinical examination, including the apnea test, or you have certain confounding factors that could not be resolved, or you have certain uncertainty regarding interpretation of possible spinally mediated movements, or in order to promote understanding of the clinical determination of brain death to families who express resistance. In all these conditions, ancillary tests would be done. Now, ancillary tests can basically be divided into two. You could have the tests of blood flow, or you could have the test of electrophysiological function. Digital subtraction angiography, or the conventional four vessel cerebral angiography, is a gold standard. Now, what do we see in brain dead patients? That there will be a patent external carotid circulation with an absent filling of the internal carotid as well as the vertebral arteries. The next test would be a radionuclide imaging studies wherein a SPECT would be done. And an absence of an intracranial isotope is usually diagnostic of brain death. This is also known as a hollow skull phenomena or an empty bulb phenomena. A transcranial Doppler is also a test which could be done. Now, when transcranial Doppler, usually they recommend that you do two examinations 30 minutes apart. The examinations have to be performed on both sides, that is bilaterally. You have to look into both the anterior as well as the posterior circulation. Now, of importance is that 10% of these patients could have had a poor acoustic window. Therefore, an earlier examination demonstrating flow and now an absence of it will basically point out towards a cerebral circulatory arrest. Now, what do we see in a brain death? Initially, there is a diastolic flow reversal. This is then as the intracranial pressure increases and the cerebral perfusion pressure decreases, diastolic blunting occurs. And finally, as cerebral circulatory arrest ensures, biphasic oscillatory flow is usually seen. A CT angiography and MR angiography, although it is performed, it has not been validated. In a CT angiography, you will have a non-opacification of the intracranial arterial circulation of the deep veins. In an MRA, you will not be able to visualize the intracranial arterial circulation. EEG, it is an isoelectric cerebral silence is noted in brain death patients. At least 30 minutes of recording is required. However, ECG is not very reliable. EEG, sorry, is not very reliable because there could be devices in the ICU which may cause artifacts. If the patient is in barbiturate coma, it may not show an electrical activity. EEG per se is significantly affected by hypothermias, various drugs, metabolic disturbances, thus diminishing its clinical utility. Electrophysiological testing is often done in conjunction with an electroencephalography. We can do an somatosensory evoked potentials or the brainstem auditory evoked potentials or the visual evoked potentials. Now, usually in an SSEP, you will see that there is an absence of electrical transmission through the brainstem and cerebrum, although there will be an intact signal in the brachial plexus as well as the spinal cord. Likewise, in visual evoked potential and the brainstem auditory evoked potentials, there is not going to be any electrical transmission to the vestibular cortex or the auditory cortex, visual cortex or the auditory cortex. Now, coming on to who can certify brain death. Now, in India, a diagnosis of a brainstem death requires a panel of 4 doctors. That is, a doctor in charge of the patient, a doctor in charge of the hospital where the patient is being treated, that is, a medical superintendent, an independent specialist of an unspecified specialty, and a neurologist or a neurosurgeon who has been nominated from the panel of names approved by the appropriate authority. However, certain amendments were made in the TOE Act of 2011, wherein if an approved neurosurgeon or a neurologist is unavailable, a surgeon, a physician, or even an anesthetist can certify brain death. Now, although various other countries basically say that single examination, including an apnea testing, is a minimum standard for determining brain death for adults, in India we follow that 2 clinical examination and apnea tests need to be done twice at an interval of 6 hours. After the second test, the team starts counseling the family regarding organ donation, and the time of death is often the end of the second apnea test. Now, medical record documentation is very important. What we do is we fill in the Form 10. Now, all phases of determination of brain death has to be clearly documented. This includes documenting the etiology of coma, the absence of confounders, a complete detail of all the clinical tests which have been performed, its results, including the laboratory values, neuroimaging results and the timing in relation to the clinical testing. Now, ancillary tests, if performed, the reason for performing and the type of ancillary tests performed, along with the results, the time of death, and the identity of the practitioners who have declared the patient brain death. Now, the time of death is usually if you have determined brain death with just a neurological examination without performing an ancillary test, the time of death documented is the time the PCO2 reaches its target, that is during the second apnea test. However, if ancillary test has been performed, the time of death is documented as the time the ancillary tests have been formally interpreted and documented by the attending physician. So coming on to brain death in pediatrics, basically the minimal criteria is the same as in adults. Probably there's an inclusion of sucking and rooting reflexes in pediatrics. Now, a newborn of at least 36 weeks gestation is required to begin certification of brain death. The observation period is different. Like, for example, a child, a neonate, basically from 7 days to 2 months, you have to give an observation period of 48 hours. However, 2 months and above, 24 hours is recommended. It is also recommended that 2 examinations, including apnea testing, be the minimum standard, with an intervening period between 2 examinations of 24 hours for neonates and 12 hours for infants and children. Ancillary testing is not routinely required. TCD has not been validated. Now, what happens after declaring brain death or death by neurological criteria? A somatic support, which is also known as physiological or an organ support, will be continued unless, or should be discontinued unless organ donation has been planned, the decedent is pregnant, and the decision is made to continue support for the sake of the fetus, or the family per se requests continuation of support due to religious or moral beliefs. This is the most important part of brain death. Now, the family should, although an informed consent is not required for proceeding on with brainstem certification, a family should be made aware that the tests are being conducted to diagnose brain death. An outline of the entire process has to be explained in advance, findings communicated with them after each set of tests, including the definitive diagnosis of death after the second This basically gives an opportunity for the families to decide to accept to the terms that their relative or the loved one is brain dead and to decide on organ donation. Now, the ICU physician, the role of his comes over here is that he should communicate the confirmation of this brainstem death to the transplant coordinator, who in turn can communicate it with the family and make requests for organ donation. So, if the family has consented for organ donation, the administrator of the hospital would be communicated to stop further billing. If organ donation is not to take place, then a time has to be set to withdraw ventilation. Now, most families would prefer to be in attendance when the final cessation of circulation occurs. We have to explain to them that the patient, it could take anywhere between 10 to 20 minutes for the patient to die after the ventilator has been stopped. Privacy and also religious and other ceremonies should be facilitated as much as possible. So this is just an algorithm to put the entire thing in a nutshell. So whenever you have a patient with a catastrophic brain injury of a known cause, his neuroimaging is compatible with the cerebral circulatory arrest. The next step would be to rule out confounders. This could be medications, toxins, it could be acid-base derangements, electrolyte imbalances. All this has to be sorted out. Then you conduct the clinical examination, including assessment for coma as well as loss of all brainstem reflexes, following which an apnea test is usually done and brain death is diagnosed. These are the references, and I hope I've been able to cover up most of it, and all of you all have benefited. Well, thank you. Dr. Sindhu?